So I'm just going to start the second part, which is drug therapy. If you want to look at drug therapy for atrial fibrillation, the best place to look for that would be the atrial fibrillation guidelines, which you can get from PubMed. And these atrial fibrillation guidelines were published by consensus statement from ACC, ASA, European Heart Rhythm Society, ESC. The last guidelines were from 2011. They get updated every now and then. But this is the gist of how we treat these patients. So this is a list of different drugs that you can use for rhythm control in these patients, which means keeping them in normal rhythm, keeping them out of fibrillation. Now, the drug therapy is based on 4 different kinds of diseases that the patients might have. If the patients have no heart disease, so as I showed you earlier, about 1/3 of the patients who present with atrial fibrillation don't have any heart disease. So in these patients, you can use almost any of these drugs. Usually we start off with drugs like dronedarone or Maltac, flecainide, propafenone, and sotalol. So you could use any of these as first-line drugs. These are easier to use. You don't need to put the patient in the hospital for these drugs. And then if they fail any of these drugs, then you can go into one of the other ones, or you can go to second-line therapy, which you would be using drugs like amiodarone, dofetilide. Now, amiodarone might be a drug which is available throughout the world. So any part of the world, I'm sure at your institution, you should also have amiodarone available. And again, flecainide and propafenone are older drugs, so they are generic drugs. There might also be some form of them available. So the second line therapy would be, if you fail one of these, then the second line therapy is either go to these drugs, or you can do a procedure in these patients, which is called catheter ablation. And I'll talk more about the procedure when we address that. Now, the second set of patients would be patients who have atrial fibrillation associated with hypertension, which is very common. It's the most common cause of atrial fibrillation as people get older. So in hypertension, you have to do an echocardiogram on these patients to look at the thickness in the ventricle. If the ventricle is very thick, if they have substantial left ventricular hypertrophy, then unfortunately, most of these other drugs are not indicated as per the guidelines. So as per the guidelines, the only drug that is safe would be a drug called amiodarone. If the patient does not have significant LVH, then again, you could use any of the drugs that were used in the first group of patients, which is dronedarone, flecainide, propafenone, sotalol. And then again, if you fail first round of drugs, then you can go to second round of drugs, or you can offer catheter ablation to these patients. Basically, the gist of these guidelines are that you have to try drug therapy as a first-line therapy. And then if they fail drug therapy, then the second line can be catheter ablation or another round of drug therapy. The third category of patients will be patients who have atrial fibrillation that is associated with heart disease, with coronary artery disease. So these patients have already had a heart attack, or they have known coronary artery disease. So in these patients, unfortunately, you can't use class 1C drugs. And class 1C drugs are flecainide and propafenone. So the only ones available then would be dronedarone or Maltac, sotalol, or dofetilide. And then if you cannot take any of these, then again, you could go to amiodarone or catheter ablation. And then finally, the last category would be patients who have heart failure associated with atrial fibrillation. In patients who have heart failure associated with atrial fibrillation, only 2 drugs can be used, and that is either amiodarone or dofetilide. Dofetilide is also known as Thicosin, as the brand drug in the United States. And I don't know how much of that is available in the other parts of the world. But it's a very effective drug to maintain sinus rhythm in patients who have heart failure and persistent atrial fibrillation. Again, if you fail these drugs, then you don't have a second-line drug therapy available in these patients. And the only option is to do a procedure called catheter ablation. So this is a useful guide for anybody who is taking care of patients with atrial fibrillation. Now, when these patients present to the hospital with atrial fibrillation and rapid ventricular rates, and they have symptoms, significant symptoms associated with that, or they have low ejection fraction and they have heart failure associated with that, we try to cardiovert them and put them back into normal rhythm. So to do that, we can either electrically cardiovert them, or we can try drug therapy. So the drug therapy that is available for cardioversion includes intravenous drugs like ibutylide. You can use intravenous procainamide, which is a very old drug, which I'm sure is available in most parts of the world. You can use intravenous flecainide or propafenone, which we don't have available here in the US, but I think it's available in Europe for sure. I don't know if it's available in your institution. You can use sotalol, which is again a very old drug. You can use oral dofetilide, which is sort of the same class as ibutylide, but it's an oral drug. And then in some patients who have idiopathic atrial fibrillation, which means without heart disease, in these patients, we sometimes use what we call pill in the pocket approach. So we tell these patients, instead of taking these drugs all the time, these are patients who probably have atrial fibrillation maybe 3 to 4 times a year. So instead of taking a drug all the time, we tell them to keep these drugs with them and only take a higher dose of flecainide or propafenone at the time that they have atrial fibrillation. That usually leads to conversion into normal rhythm within 2 to 3 hours. Whenever we use any rhythm control strategy, we have to make sure that the patients are taking rate control, which means they are on some form of AV nodal blockers to prevent the ventricular rate from being fast. And the reason for that is many of these rhythm control drugs, if they're given alone, can convert atrial fibrillation into atrial flutter. And if that happens, the ventricular rate will actually speed up. Because the atrial flutter is a slower rhythm, so it can conduct much faster to the ventricles. If the patient is not taking AV nodal blocking drugs and you give a rhythm control drug to these patients, you can actually make them worse. So we always teach our trainees that anytime you're using a rhythm control drug in atrial fibrillation, you've got to make sure the patient is on AV nodal blocking drug. So what are some of the new drugs? These are some of the drugs that are in the pipeline. Some of them have been developed. So dronidrone is a drug that is similar to amiodarone, except it doesn't have the side effects that amiodarone has, which are associated with the iodine thing. And that would include effect on thyroid function, on long-term effect on the lungs, as well as on the liver. So it's supposed to not have many of these side effects. However, we've been using it for a long time. The efficacy of this drug has not really panned out. And it might be that amiodarone being associated with the iodine moiety helps it to be more effective. There are other atrial specific drugs. So these are drugs only affect the atrial channels, and they are also in the pipeline. Vernaculant has already been approved for acute cardioversion, and there are other gap junction enhancements in the works to make them more effective for atrial fibrillation. Now, how do we assess the success of drug therapy? The problem is that atrial fibrillation is, as I told you, is more of a systemic disease. So it's not a localized rhythm control problem. And so it's very hard to cure it or to treat it completely eradicate it. So in some patients, the success of atrial fibrillation therapy is actually decreasing the burden of atrial fibrillation. It's not completely eliminating it, but to decrease the burden. So it could be you decrease the time to first recurrence, which means the patient was having episodes 3 to 4 times a month. Now, with this drug therapy, they maybe have episodes maybe once in 2 to 3 months. So that would be called a success, even though they still have atrial fibrillation. So that's a common thing that I see many times when I treat these patients and send them back to their primary care providers, and they have an episode of atrial fibrillation. They call me back and say, the therapy failed. I tell them the therapy did not fail. It has decreased the incidence and it has decreased the burden of atrial fibrillation patient. And that is probably the best thing that you can do. You can decrease the duration of episode. Some patients might be having episodes that are lasting as long as a few hours or even a day or two. And now they have episodes that only last for a few seconds or sometimes few minutes. So that might be a form of success for these patients. And then,
Question.
yes, go ahead.
Most of these drugs you just mentioned, we don't have in the hospital. At times we use digoxin.
Very important to know the success of atrial fibrillation is you have to have a reliable way to monitor the burden of atrial fibrillation, which means you have to be able to monitor the amount of atrial fibrillation that the patients have. And that you have to figure out what are the resources available to you. Obviously, in more advanced countries like US, we have implantable devices that we can implant in patients, which can record atrial fibrillation and let us know. Nowadays, there is a push of recording these things through things like the Apple Watch. There are things that can be put on the phones, which can record these things, so which is easier for people. It depends on how much of this technology is available. I sometimes use very simple things with patients, which is blood pressure measuring instruments. So almost everybody, you can, I'm sure they can buy or have access to things to measure the blood pressure. And any machine that measures blood pressure also measures the heart rate. So that is one simple thing that I use with my patients, to do that once a day so they can know when they go out of rhythm and when they are in atrial fibrillation. But you have to have some reliable way to measure that. That is the only way you can know what the burden of atrial fibrillation is.